Everyone, thank you so much, Dr. Shakir, and thank you for the organizers for organizing this amazing meeting, for inviting me to speak about updates in GI cancers. This is a long topic, so we'll try to okay. So we'll speak about different subjects, including esophageal cancer, pancreatic, HCC, and new updates in TNT treatments in rectal cancer. Starting with esophageal cancer. So recently, publication of the well-known cross trial long-term data update with median follow-up of 147 months with absolute 10-year overall survival benefit of about 13%, 38 versus 25%. This benefit persisted from their initial publication and included both two histological subtypes of adeno and squam. The isolated locoregional and synchronous locoregional plus distant metastasis, as well as persisted in terms of benefit. Following cross trial and all the perioperative chemotherapy trials in esophageal cancer, came a trial that compared those two modalities just to find an answer, which way is better. It's recently published New Ages trial comparing tri-modality cross-regimen versus perioperative, which is MAGIC and FLOT regimen. So those are the two arms. The radiation was 41.4 grays in 23 fractions cross-regimen, and they included similar patient population, T2 to T3, and N+ patients. All patients were metastasis-free. Their primary endpoint was overall survival. And overall survival, as well as disease-free survival, was similar in those two modalities with regards to cross-regimen versus perioperative concurrent chemo radiation. The perioperative mortality was about 2 to 3%, which is much less than the previously reported cross-regimen of about 10% perioperative mortality, likely due to this trial was done in more tertiary and more experienced hand surgeons. I'd like to draw your attention to multiple points, including the rate of R0 resection, the rate of YPN0, as well as the tumor regression and pathologic complete response. Not surprisingly, the radiation arm did much better. It's a local control modality. If you can see also on the right hand of this slide, the toxicities between those two modalities, the cross-regimen preoperative concurrent chemoradiation wins in all of those except odenophagia, which is not surprising since we're targeting the esophagus. A critique to this trial comes at multiple points. So currently the perioperative chemotherapy standard is not as it's used to be in the MAGIC trial ECF. Currently the standard is FLOT, especially in adenocarcinoma. This trial, only 15% of them were FLOT, where all the others were ACF. So does it really represent the standard of care in chemotherapy? Maybe we need more data to present that. Only 10% of patients were females, and it was designed as non-inferiority clinical trial. The experimental arm here was the chemotherapy, which is a very toxic sort of regimen. In my opinion, when you have the experimental treatment more toxic, you would need a superiority sort of trial to justify using toxic treatment in treatment of this disease. Also, in the past couple of years, an interesting systemic therapy trial came out about adjuvant nivolumab in resected esophageal or GE junction tumors. This is published in New England Journal. Patients who were treated with cross-regimen, preoperative concurrent chemoradiotherapy. Everyone else who was not treated with cross-regimen was not included. And they provided nivolumab to those with residual pathologic disease, as well as those with positive margin. And the other arm was placebo. As you can see here in this graph, nivolumab doubled disease-free survival in those patients from 11 months to 22 months, which is a great thing. And medical oncologists are starting to like cross-regimen much more, as this gives them a path to use nivolumab in the adjuvant setting, where they can't do that with perioperative chemotherapy. A question that was addressed in the past in the well-known Minsky trial of esophageal cancer, however, was done in a time where 3D conformal planning was being used, or 2D at that time. A new trial that addresses the question about dose escalation in esophageal cancer, Arditeco study. They included medically inoperable or irresectable esophageal cancer patients with tumors of T2 to T4 N+, all were M0, and all patients were candidates for dose-escalated concurrent chemoradiotherapy. The two-dose escalation, or the two dose levels were 50.4 grays and 61.6 gray, were all delivered in 1.8 gray per fraction, so conventional fractionation. Again, shows similar results to what we know already about the likelihood of no effect of dose escalation in those patients with regards to progression-free survival. Some thought that squamous cell carcinoma would have better response with dose escalation, extrapolating from head and neck practice, and some applies that in practice, actually. You can see in the diagram B in this slide that didn't even show for squamous cell carcinoma, as well as for adeno. Another trial that also published recently, PRODREACH, had similar results. Moving to a topic where our role is increasing in the past few years, hepatocellular carcinoma. Recently published RTOG 1112 randomized phase 3 study comparing sorafenib versus SBRT plus sorafenib in hepatocellular carcinoma in the locally advanced setting. So it used to be for those patients with locally advanced disease, large disease, and that were not candidates for surgical resection, or local modalities like RFA or TACE, were always candidates for systemic therapy. And the systemic therapy at the time of this study design was sorafenib, changed only in the past year or so. So they included locally advanced patients, refractory or unsuitable for resection, or TACE or RFA. They were all good child PO-A patients, had good platelets, and 20 centimeter sum of HCC, meaning all the HCC lesions in the liver were measured in one diameter, and then the sum was less than 20, less than 3 centimeter extrahepatic HCC. They, of course, allowed vascular invasion, micro and macro, both. Patients were stratified according to well-known factors that can change patient outcomes, including vessel invasion, including metastasis as well, and hepatitis C versus not, amongst other factors. Radiation dose ranged from 27.5 to 50 gray in 5 fractions, given in alternate days, not daily. This was followed by sorafenib. Primary outcome was overall survival, and showed a significant increase of about 3 months in median overall survival. That benefit persisted over time. So it's definitely a new standard of care and a new paradigm that should be offered to those patients, especially those with macro invasion of the major vessels. where usually they are given systemic therapy alone. This is some variables that they included in their publication, including the effect of multiple things. Patients with good performance status did better. Patients with no metastasis did better. 4%, by the way, of this study was metastatic patients. Patients with macrovascular invasion did worse, which is not surprising. You can see the hazard ratio is almost similar to having an M1 disease, and in staging it's considered M1. What's surprising for me is the Child-Pugh score. So Child-Pugh A5 versus A6 is a major difference. I always thought that Child-Pugh A and B would have been more difference, but even within A, the number of points is different. And if it's biochemical versus clinical Child-Pugh score, that makes another difference as well. Biochemical is worse, of course. One issue came at the time of preparing that RTOG study for publication is a publication also in the New England Journal of Medicine about comparing similar population of patients with the standard of care, sorafenib, but comparing it with atezolizumab and bevacizumab. Primary outcome was overall survival, and to the surprise, it showed improvement in overall survival, as well as in disease-free survival. This is significant and made a paradigm change also in management of HCC. The question came, well, we have the data of RTOG 1112 and the immune therapy data. Now, how do we deal with SBRT? Because it was given in the clinical trial with sorafenib, which is not anymore the standard of care. Recently, more and more data are coming, mostly are retrospective, about SBRT plus immunotherapy versus immunotherapy alone or versus SBRT. This is one of those data that compares SBRT immunotherapy versus SBRT, and it shows, as you can see, a statistically significant difference in overall survival in favor of SBRT. However, a good clinical trial that is actually currently being accruing, multiple ones, would compare immunotherapy versus immunotherapy plus SBRT. So, okay, this is a new interesting trial as well, HE1, which compared palliative radiotherapy for liver, giving whole liver, 8 gray in 1 fraction compared to best supportive care in patients with end-stage HCC or liver metastasis. Just to the surprise, not only they benefited from pain control, but they also had trend in overall survival. Those patients were planned using POB fields, being treated and SIMmed on the same day. Few organs at risk needed to be contoured. For the sake of the time, I'll go to the next. Pancreas cancer, just earlier this past October, pre-op panc was published. We are gaining our role back in radiotherapy and pancreas. Patients with resectable and borderline resectable adenocarcinoma were either randomized to standard of care, FOLFIRINOX, which is very toxic regimen, versus concurrent neoadjuvant concurrent chemoradiation with gemcitabine, and a low dose of radiation of 36 grays and 15 fractions. It was similar in all outcomes, and toxicity was less with the concurrent chemoradiation. So in tumor boards, we should advocate more for the concurrent chemoradiation from now on, as it's less toxic, especially for patients who cannot tolerate the FOLFIRINOX. Just a reminder that recently the screening recommendation for rectal cancer is changed to age 45. This is a summary of all or most TNT trials and their outcomes. As you can see, they all agree that patients with T4, those with N2 plus, should be treated with TNT and had improvement in their local regional control. Some of them included EMVI and CRM positivity. We'll go to a very recent or a recent update published in Annals of Surgery in October 1st, 2023, Rapido trial update. So short course TNT-based regimen versus long course conventional regimen. Benefit was shown. However, in recent update, local regional recurrence in the experimental arm was detected more often, 10% versus 6%, with more often a breached mesorectum patients, so 21% versus 4%. The significant predictors for local regional recurrence in the experimental arm were included positive CRM in large lateral lymph nodes, tumor deposit, and node positivity. Okay, final slide or final study, about organ preservation. The OPRA trial included patients with stage 2 or stage 3 biopsy-proven rectal cancer. They were all properly staged, so meaning with MRI, colonoscopy, and CT chest, abdomen, and pelvis. Patients randomized to either induction chemotherapy followed by chemoradiotherapy, or with upfront concurrent chemoradiation followed by consolidation chemotherapy. The dose ranged from 45 to 56, depending of regional lymph nodes or large primary. They also allowed inclusion of inguinal lymph node, which is something we don't usually include in rectal cancer, but only in those that had anal canal involvement. So TME-free survival, those patients were randomized, second randomization to either having watch and wait versus surgery. Those who were in the watch and wait protocol with upfront concurrent chemoradiation, organ preservation was much more and more significant, as well as less regrowth rate. Last slide about the recent publication last month about 5-year outcomes. The upfront concurrent chemoradiation benefit still persisted. You can see 50% of patients at 5-year were able to be TME-free surgery and having their organ function normally. Thank you so much.